Hello, everyone. Hello, everyone. Thank you for joining us this afternoon. I have the pleasure of introducing our Rapporteur Session for this conference this week. These are our unsung heroes of the International AIDS Conference, the folks who are diligently keeping track of everything we're learning and reporting, and without them, we would be nowhere. And I wouldn't learn half of the things that are happening at the conference. So this is a really special session. My name is Owen Ryan. I'm the new Executive Director of the International AIDS Society. I am 4 weeks on the job, so please forgive me if I'm a little rough in this session. We're going to start right in, and I have a second job today for our folks here, is that I get to be timekeeper. So if you hear me doing the not so polite, that's kind of a not so subtle signal. So I am first going to introduce our Track A rapporteur, who is sitting next to me. I have Dr. Sabrina Brumet. She's an assistant professor in the Faculty of Health Sciences at Simon Fraser University and an associate scientist at the British Columbia Center for Excellence in HIV/AIDS in Vancouver. Her research focuses on HIV diversity, molecular epidemiology, and adaptation to its human host.
Thank you very much. I want to give all the credit to my excellent Track A rapporteur team members, who were Dr. Matthew Parsons from the University of Melbourne, Dr. Renee van der Sluis from Monash University, Dr. Nilu Gunatilaka from UNC Chapel Hill. Unfortunately, Dr. Jen Maroa from UKZN could not join us at the last minute due to visa issues, and Dr. Mark Brockman from Simon Fraser University and the BC Centre for Excellence in HIV/AIDS generously stepped in. So a very big thank you to my team members. There was a palpable sense here at AIDS 2014 that we've really entered a new era in our fight against HIV. And what I'm talking about is the possibility of a world without AIDS is no longer just a dream. One of the advances that has been made to facilitate this new era is substantial improvements in our understanding of HIV latency, and those advances featured prominently in Track A at this conference. That said, despite these advances, numerous knowledge gaps, challenges, and complexities remain. Dr. Deborah Persaud outlined the recent developments in the Mississippi child who recently suffered plasma viral rebound after 27 months of remission. And this teaches us just how early the reservoir is seeded in HIV infection, in this case within hours of infection. Karine Van Lint outlined the complex molecular epigenetic and non-epigenetic mechanisms of viral latency, while Melissa Churchill gave us an overview of the anatomical sites where HIV hides, the fact that they might differ with respect to their pathogenesis of latency, and also might differ in their ability to be safely eliminated therapeutically. Sarah Palmer outlined the many challenges in quantifying the latent reservoir and assessing replication competence of these proviruses, and urged us that novel, standardized methods are urgently needed to move the field forward. Nicolas Chaumont talked about the extraordinary heterogeneity of T-cell subsets in terms of their contribution to the total reservoir, their longevity of persistence, and their susceptibility to reactivation, again, by therapeutic approaches. That said, despite these challenges, we are starting to move forward with potential approaches to achieve sustained HIV remission. It is generally agreed upon now that early HART will be essential for this process to reduce seeding of the viral reservoir, and in the words of Dr. Tony Fauci, to stack the deck in favor of eradication. After this, what's being talked about is a combination kick and kill approach, a three-pronged approach that will involve reactivating the latent reservoir with anti-latency agents, potentially using gene therapy approaches to eliminate CCR5 positive cells, and also use vaccine or immunotherapeutic approaches to boost antibody and T-cell immunity to clear residual viremia and infected cells after reactivation. And what is being hailed as the breakthrough in Track A at AIDS 2014 was a study by Ole Sogard, who talked about a phase 1-2 non-randomized trial of 6 individuals where the HDAC inhibitor romidepsin was shown to safely activate latently infected cells and induce transient quantifiable plasma viremia, something that had never been shown before for an HDAC inhibitor. Alternative strategies to kick and kill, however, were also discussed at this meeting. Not only alternative strategies, but opposite strategies, namely strategies to maintain latency via permanent silencing. And this is because of a growing realization that the persistent release of HIV, small amounts of HIV during HAART actually could contribute substantially to pathology and immune activation, and we might need to silence this to achieve remission. Hiromi Imamichi, in a late breaker presentation, showed that on HAART, the vast majority of proviral DNA copies are actually defective. They're truncated. However, they make HIV RNA transcripts and they make HIV proteins too. She referred to these as zombie proviruses. She speculated that these products could be drivers of chronic immune activation, and if so, we would need silencing approaches to counteract them. Eric Verdun showed a very elegant study that his lab performed at shRNA library screen, where they identified host proteins that contribute to the modulation of latency, and also showed that mTOR pathway inhibitors could block reactivation from latency, showing that silencing approaches could possibly be feasible. Also exciting in vitro data on this subject from Kazuo Suzuki, who showed that short hairpin RNAs targeting the viral promoter region could also be used as a strategy to sustain latency. We also saw major exciting advances in the tracking of individual viral genomes to study viral reservoirs. Jake Estes had a new technique for sensitive detection of SIV RNA and DNA in tissues, useful to examine viral reservoirs and anatomical locations. And Brandon Keel presented a study that, to be quite honest, was just really cool. He generated viral stocks where there's up to 10,000 unique viral variants in these stock, each labeled with a unique molecular barcode, and upon experimental infection, one can track where each and every one of these viruses go in an animal model. So again, useful tools for latency studies moving forward. It wasn't all cure here at AIDS 2014. There were also advances in vaccine research that were discussed. And although it's generally agreed upon that a successful HIV vaccine would have to elicit multiple arms of the immune response, Dr. Tony Fauci and Dr. Antonio Lanzavecchia really outlined neutralizing antibodies as a major advance that the field has enjoyed in recent years. To summarize, we now know that approximately 20% of people go on to make neutralizing antibodies of the type that we generally think we might need to elicit with a protective vaccine. And this process we now understand a little bit better. It turns out that the evolution of broadly neutralizing antibodies comes about during this exquisite process of coevolution between virus and host that drives the evolution of breadth over a period of months to years following infection. How are we going to harness this with vaccine design? Well, through a strategy that Dr. Tony Fauci called B-cell lineage vaccine design. What we're going to try to do is recapitulate but accelerate the naturally occurring coevolution process by sequential, iterative vaccination in a prime boost method with evolving envelope antigens. It ain't going to be easy, though. Penny Moore talked about the challenges to this approaches, namely that there's different regions on the HIV envelope that differ. The neutralization epitopes, there's different ones on the HIV envelope, and they differ in the developmental pathways that lead to them. For example, neutralizing antibodies that target the CD4 binding site take years to mature, and they are heavily mutated away from their common ancestor. On the other hand, V1, V2 antibodies don't take that long to mature, only months. They don't need that much somatic hypermutation, but the antibody precursor that you need to start with are extremely rare antibodies with these very long CDRH3 domains, and these represent unique challenges to the B-cell lineage vaccine design moving forward. We saw major advances in antibody engineering for treatment and prevention here at AIDS 2014, strategies to improve upon nature, if you will. So Jia Guo talked about a single gene bispecific immunoadhesin, an antibody-like molecule. This molecule encodes anti-envelope and anti-CD4 domains, and it was capable of neutralizing 100% of viral isolates tested in vitro. Rick Kaup had some really exciting data on how CD8 positive T cells that are not HIV specific can be harnessed to be HIV specific in the lymph nodes by using a similar bispecific antibody, in this case one containing anti-CD3 and anti-GP120 domains. It wasn't all antibodies here in the vaccine session. Last night, Jonah Sasha presented a very exciting update to the Lewis Picker's CMV vaccines that showed extraordinary protection in macaque models. And they were even more extraordinary because it was shown that the T-cell epitope recognition patterns elicited by this vaccine basically broke the paradigms of traditional cellular immunity in that the majority of CD8 T-cell responses in that vaccine were not restricted by MHC class 1, but rather they were restricted to MHC class 2, which was astounding. What was more astounding last night is that Jonah now has elucidated the MHC class 1 responses. Turns out they're not actually restricted by classical MHC class 1. In fact, they are all restricted by non-classical MHC E. So this is unprecedented and is a completely novel immune response against HIV that will generate excitement moving forward. I briefly want to mention advances in virology, especially host restriction factors. Federica Nudi showed new data on the further elucidation of a novel restriction factor, MX2. She showed that there's genetic variation that's clinically relevant in human populations within the gene encoding this host restriction factor. Matthew Woods from Canada further expanded our knowledge on the novel restriction factor HERC5. He showed mechanism. This HERC5 interferes with Rev-mediated nuclear export of HIV RNA. And finally, Kenzo Tokunaga shared with us his new discovery of a new restriction factor, March8, which blocks envelope incorporation into the virion, thereby reducing viral infectivity. Back to immunology. A major theme in this year's track was moving immunology beyond the blood to the places in the body where the fight against HIV is actually waged, and these are the tissues, the genitally tract, the gastrointestinal tract. And the reason for doing so was shown clearly by Jake Estes last night. He showed that after about half a year of suppressive antiretroviral therapy in an SIV model where there was plasma virus suppression, there was still low-level viral production in lymphoid tissues, incomplete reversal of damage to the GI tract, and sustained immunoactivation, showing that we really need to focus beyond the blood. There was exciting new developments, again, continuing on the theme of tissue immunology. In human studies, novel correlates of HIV acquisition were identified. Shahid Abdulhaq showed that in HIV-exposed seronegative female sex workers, there is high-level expressions of interferon epsilon in cervical epithelium, suggesting that interferon epsilon possibly could have anti-HIV activity. Laura Romas showed that in HIV-exposed seronegative men, there is an overexpression of antiproteases in rectal mucosa, also identifying antiproteases, potentially anti-HIV activity. Finally, on the correlates of risk side, Godfrey Kukosi showed that the presence of certain cytokines are associated with increased risk of seroconversion in men. All of these studies point to potential for novel microbicides or the use of topical inflammatories, anti-inflammatories for use in HIV prevention. More on the theme of novel interventions, Alexandra Ortiz in a non-human primate model of immunodeficiency virus infection showed that treatment with probiotics and IL-21 reduced disease progression as well as reduced gut pathology in ARV-treated macaques, while Francois Villinger showed that blockade of the alpha-4 beta-7 integrin receptor delayed vaginal SIV acquisition and also subsequent dissemination of the virus into the tissues.
We have 1 minute, just to let you know.
Okay, this is my second to last slide. Finally, chronic immune activation emerged as a major point of discussion at this conference, namely how it contributes to pathology and what we're going to do about it. And interestingly, a role for HDAC inhibitors emerged as a point of discussion. Anne-Sophie Kajere showed the results of a phase 1/2 non-randomized trial showing that treatment with the HDAC inhibitor panobinostat significantly reduces inflammation. highlighting a potential role for some HDAC inhibitors as anti-inflammatory agents. And I say some because last night, Christian Appertry, in a non-human primate model, showed that the HDAC inhibitor romidepsin enhanced virus replication and T-cell activation. So I think this is going to be a point of discussion and debate moving forward. Finally, I apologize that in a 15-minute session, many of the excellent research that were presented here had to be left out of the presentation, but I hope you agree with me that AIDS 2014 Track A featured very exciting advances in cure and vaccine research, as well as basic and translational research in the immunopathology of HIV and SIV. And in a shameless plug for my hometown of Vancouver, we look forward to welcoming you all at AIDS at IAS 2015 next year. Thank you.
Thank you, Sabrina. That was incredibly well done. Thank you. So our next speaker is going to be Cristina Mussini. Cristina Mussini is a professor and director of the infectious diseases clinics of the University Hospital of Modena in Italy. She is a member of the board of the European Clinical AIDS Society, member of the scientific committee of the European AIDS Conference, and of the European Glasgow Conference. Thank you, Cristina.
Thank you for the invitation. So I will tell you the story of the Track B. We have good news. We know that the number of people receiving ART increased from 2 million in 2005 to 13 million in 2013. This in low and middle income countries. And that also in developed countries, let's say that the retention in care and the results of treatment, so the rate of patient with an undetectable viral load has reached very good results. But where do we have to step up the pace, which is the title of the conference? Actually, in naive patients, we have seen the data from the modern study that showed that Duan therapy is worse than triple therapy, even if the genotype, the result of the genotype is comparable to the one of Trophile for tropism, for detecting tropism of the virus. When the patient is undetectable, switching could be risky. These are the data from the Cannock cohort in Canada, even if the data, I think they are preliminary. When the patient is experienced, we have learned from the second-line study that probably not all second-line patients are the same, and there are some of them that are at higher risk of failure. But when they fail, if they are using a drug that has a high genetic barrier as dolutegravir, they do not develop resistance, not for dolutegravir or for the other drugs. We have talked a lot about adherence because really we have to improve adherence because as clinicians, we significantly underestimate the adherence in our patients. This study was conducted in children, but it's the same in adults. And there was this very interesting study conducted in China where they showed that we can certainly improve adherence by intervention by using cell phone. In adolescents, adherence could be increased just by disclosure of the disease that they have, so they understand that they are taking medication for a certain reason, and so they can be much more motivated. If the problem in retention in care is very relevant in adults, this is not the case in children. We have seen very good data also in children with TB because obviously the parents are taking them to the clinics. While, as I said, in adults it's proven even in pregnancy. The result that has been shown show that postpartum, so post-delivery, is at a much higher risk of loss to follow-up than during pregnancy. But really we have to improve the problem of retention in care in all our settings, not only in developing countries but also in developed countries. In fact, inflammation is certainly bad, but the picture is not really clear yet. We have seen the data from the Ardent study where 3 different drugs did different things on the cytokines, so we don't know. I mean, at present, antiretroviral therapy did not have a role in inflammation, at least an univocal role. Talking about neurocognitive impairment, we have seen the data from the Charter study showing that a certain percentage of patients can improve their cognitive status over time, even if some of them decline it. And the sustained undetectable viral load has a relevant role in this topic, but we still have to do better with other factors that can play a role, as other comorbidities involving the central nervous system, or also albumin and hematocrit. We have seen a study conducted by Andrea Antinori in Italy that showed that efavirenz, he was not talking about the neuropsychiatric side effects of efavirenz, they are well known, but the neurocognitive impairment of patient on efavirenz, actually there was no association, even with a very strong pattern of tests. Talking about cancer, we are starting to study cancer also in low and middle income countries, and you see they are still relevant either in HIV negative or in HIV positive, and the distribution is not very different between the two groups, but the HPV vaccine is working. There has been a study conducted by the group of Mario Clerici, and really we have seen that there is this important immunogenicity of the vaccine. There was the risk factor for cardiovascular disease in the DAD cohort, showing that the pre-ART BMI is important as a risk factor for cardiovascular disease and also for diabetes. COPD could be the next problem. Actually, is very. It's important. You see, we have about 7% of patients with COPD, but especially in smokers. So we really have to step up the pace in asking our patient and helping our patient in stop smoking, and this will help them also with cardiovascular disease. Liver fibrosis should be measured in HCV co-infected because it's really linked to the liver-related death and major liver events, but it's also important, and it's been a couple of studies that have shown this, that the role of HIV per se that could develop by through the action on stellate cells could have a role, independent role from the HCV. Talking about HCV, we know from many trials. Here we have seen the turquoise, for example, but also we have seen more data in other conferences without ribavirin. That would be even more important for us to have. So they are not no more a special population concerning the viral response, but especially if they are using methadone and buprenorphine. And this was a very interesting study conducted here, presented here. And so with the new drugs, we can really do better. But really, maybe we have to change the mind of the doctors. This Swiss study was presented in a session, and it was interesting to see that among 216 patients, only 16 were treated. So we really have to change. Maybe the new drugs will help us, because if you see the contraindication, mainly were related to interferon, but sometimes we think that the patient will not be adherent, that he will not take properly the medication, but for sure we have to certainly change the mind of pharmaceutical companies and payers concerning HCV, and we have to learn from the HIV experience. So this was the presentation from the Clinton Foundation, and I think that it was really inspiring. In low and middle income countries, we have absolutely to increase the access to tenofovir in patients co-infected with hepatitis B, because the rate of tenofovir is really too low. And finally, when we look at TB, I really think that we have reached an incredible success until now, with over 40% decline in HIV TB death and over 1.3 million lives saved. But we have to diagnose HIV in patients with TB, because the rate of diagnosis is really too low. Only 40% of TB cases they knew their HIV status, and we have to monitor and fix the cascade of care of HIV and TB patients, which is much, much worse than the other cascade of care that are not perfect as we all know. New combinations have been presented, and they really look promising with this new drug plus moxifloxacin and pyrazinamide. And this is the decline in the culture, and I think really that it's important. And also some preliminary data on a vaccine were presented, so we have to wait for a vaccine to come. I want to thank you for your attention, but especially I want to thank the Rapporteur staff for their incredible work. I want to thank John Gill from Calgary in Canada, Sabrina Kitaka from Kampala in Uganda, Silvia Nozza from Milan, Mark Bloch from Melbourne in Australia, and Andrea Kosaritza, who is actually a professor of immunology, but he's my husband, so he helped us a lot. So thank you very much.
Thank you, Christina. Great job. Our next speaker for Track C is Rick Altice. Rick Altice is a professor of medicine, epidemiology, and public health at Yale University, where he serves as the director of clinical and community research. He has focused his research in clinical care activities, creating and testing innovative models of care that focus both on treatment and prevention for vulnerable populations, including people who inject drugs, men who have sex with men, female and transgender sex workers, and prisoners. Thank you, Rick.
Thank you so much for inviting me to be here. And before I begin, I'd like to acknowledge the traditional owners of the land on which we meet, and the Wurundjeri, let me say it right, Wurundjeri, people of the Kulin Nation, and pay my respects to the elders past and present. I also would like to sort of acknowledge the incredible work that was put forward by my assistant rapporteurs, some of whom stepped in at the last minute when some of our rapporteurs were unable to make it. This is a rainbow coalition of people from 5 different continents. Elizabeth Bokusi from Kenya, Kana Hayasi from Canada, Howie Lim from Malaysia, Ruth Ann Marcus from the States, Mark Stuve from Australia, and Maria Veres from Brazil. And just to put it into context, there were over 550 abstracts and 25 sessions that they covered over this time period. And in recognition of that large numbers of coverage, we were only able to cover some of this, and so there's a lot more to see, but we tried to sort of pull this together. So I think in putting this together, there was a sort of a consensus that the group came together on after looking at the sort of the breadth of what was presented here at this conference. And so I think nonetheless, prevention certainly remains crucial for ongoing control of the epidemic, and the sort of debate that I think is dialectical that really talks about prevention and treatment as 2 separate things really need to sort of be combined and not sort of seen as separate. With regard to the trials that we've seen in other conferences such as CAPRISA, IPREX, et cetera, that were sort of game changers that really brought us to a new level of movement with regard to the prevention field, there wasn't a lot of that. I think there was a lot of information that was confirmatory. There was information about helping us to understand what is sustainable. And I think that some of my colleagues may sort of focus on some of the implementation issues, and we'll get into some of those as well as it relates to prevention. Now, there were some really important innovations and some sort of groundbreaking presentations here. Some of them involved 6 or 7 presentations from the Lancet series that was focused on sex work, and that was a major theme of this conference, and I'll speak a little bit about that. I think one of the other sort of things that was really important is that we have all of these sort of randomized controlled trials that really provide us with a fair amount of internal validity that these trials work in the people that we select them to do. But there were at least 2 open label trials that I'll present some of the findings for that really shows that there's really quite good external validity and that patients are really quite good at deciding whether they need it or not. There was ongoing and multiple presentation support for whether you want to call it TASP, TISP, or T for P in the idea that treatment is as or is for prevention across a number of different domains, but it's not necessarily just the silver bullet, that there are lots of nuances and contingencies in different contexts. There were numerous modeling studies, I think, that sort of helps give us a glimpse for the future, and then there were some ecological studies that sort of confirmed some of the previous modeling studies. We got to see a little bit of what is going to be in the future. There were some new trials that were incomplete that we saw some preliminary data for, and I think some of them will be quite exciting in the next couple of years that comes. And I think that one of the things that was sort of reassuring and it sort of brings many of the scientists back to a really important level of humility is the inclusion of voices of key affected populations with a couple of notable absences at this conference, that is young women from sub-Saharan Africa and prisoners who were not necessarily at the table to the same degree that others were. We have learned that there are a ton of, whether they're behavioral, biological, evidence-based interventions that we see for prevention. Some of them are things that have been around for a long time, such as behavioral interventions. There are medication-assisted therapies that are used. And I think some of the emerging things that we're starting to get a glimpse at, and we'll talk a little bit more about, are some of the emerging mobile technologies, especially for young adults and teenagers. But most of these interventions are really a focus on the individual. And one of the sort of emerging themes across almost every single session was the notion that we've got really a lot of structural HIV prevention issues that we need to sort of come up with. And although there weren't a lot of specific interventions that actually change the structure per se, we did get some insight into that. So yesterday we had a tour de force presentation on the promise of new prevention technologies that we hopefully will see some more information about in the next couple of years. It was presented by Ken Mayer. There were a number of new oral PrEP strategies that are going into phase 1, 2, and 3 studies, a number of new medications that include antiretrovirals, but also the promise of potentially using monoclonal antibodies. There are also new delivery systems that are more user-friendly to patients, such as vaginal or perhaps rectal microbicides, intravaginal rings that can also co-formulate contraception, long-acting injectables that may actually sustain themselves for up to 3 months, and some nanofiber films like your little breath mints that you can actually take as a PrEP on demand. There was some information with regard to male circumcision with new techniques and some trials with regard to task shifting. Now, one of the things that was a little bit disturbing is that when it comes to prevention, the level of funding has not really changed, and in some ways it sort of represents the sort of the types of studies that were available at this trial with this conference, with marked reductions in funding for microbicides and not really a lot of information here that was presented, with increasing amounts of treatment as prevention that we'll hear about from all the way from B through Track E and the community. Let me first talk about a population, a key population that was one of the foci of this conference, and that is female sex workers. And one of the things that we learned from a plenary session was the extraordinarily high prevalence of HIV and STIs across a number of settings and contexts. We did hear about some settings that were relatively low and what is the potential for transmission later on. But the other important thing that I think was brought home to us when we're thinking about the interventions and how we're going to roll out certain prevention technologies is that these individuals come in lots of flavors and heterogeneity. Female sex workers should not be sort of considered to be the same as male sex workers, nor the same should they be conflated with transgendered sex workers as well. And one of the problems that was emerged across a number of different sessions was the issues around migration, that individuals in the sex work industry often move quite frequently within the course of time, even in high-income countries, with as frequent of migration as 13% per year in places like Vancouver, but quarterly in low and middle-income countries in Asia. As part of this idea and notion to think about the potential HIV infections averted through structural change, one of the Lancet series papers that was led by Kate Shannon, who could not be here, but presented by Stephanie Strathy, was really a tale, almost Dickinsonian, a tale of 3 cities, if you will, Vancouver, Mombasa, and Bellary, India, that looked at some very, very different sorts of ways to look at how you might actually intervene, and the heterogeneity of location and context. So just starting with Vancouver, which is in the green, what you can see is that this place it's a concentrated HIV epidemic with fairly high antiretroviral coverage. So there are also unfortunately combined frequent effects of client physical violence that occur, police harassment, and elimination of one single one of these sort of structural interventions such as violence exposure and inconsistent condom use due to client violence, etc., would have a very little impact. However, if you combined all three of these together, you can begin to see some sort of reduction in HIV transmission for this group. Moving on to Mombasa, this is a place where there are high levels of sexual violence and police harassment also. It's a concentrated HIV epidemic, but with fairly low antiretroviral coverage. And here you begin to see an increase with antiretroviral coverage, sort of reducing HIV transmission quite consistently, but also the importance of what would happen if you had peer-led sex worker related outreach, which would also have an impact. And in Bellary, there's a low HIV prevalence here. There's already a fair amount of support for sex workers where there's already existing combination prevention, which is structural and community-led, that have already reduced a fair amount of the violence. So you don't see much of a change here. But one of the sort of the game changers across all of them when modeling this is that these structural interventions such as safer work environments for sex workers who are also very heterogeneous and decriminalization, especially decriminalization across all of them, would actually have the greatest impact in reducing that. So the question is, how do we do that, and do we have a formula for doing that? Moving to a single setting, Linda Gale Becker presented some data on combination prevention in the Republic of South Africa, where it is already a concentrated epidemic, but even higher prevalence among female sex workers with prevalence exceeding 50%. And what they looked at was they modeled the impact of a reduction in new HIV infections, not only for the sex worker herself, but among their male clients. And what you see is that for sex workers that you, in this high prevalence setting, that for those that are negative, there's a reduction in transmission if they were to use oral PrEP, and it would not be quite as much if they had a vaginal microbicide in PrEP in that setting, but that you get the most bang for your buck by using a vaginal microbicide and PrEP and test and treat in this setting. And then at least for the clients, test and treat approach would actually have the most impact on clients. So looking that one size does not fit all, but a combination is probably likely to have the most effect. I have unfortunately used the wrong name for this presenter, but I thought it was our whole team thought it was a really fascinating presentation. And what they did was they looked across a number of countries looking at where they could find the prevalence of HIV among male sex workers, so transitioning from females to males, and they sort of plotted that out in terms of high to low prevalence of HIV, and then they sort of looked through the laws and the protections, the human rights protections that were available, and they sort of codified those over. And using 4 different models where they controlled for a number of different things, the association between human rights protections, so improving the lives of male sex workers, whether it's by striking homosexuality laws, criminalization for that, to criminalization for sex work, etc. For any one of the models that were used, it portended a 5.5 to an 8.2% reduction for each human rights protection, really suggesting that we've got a lot of work with our legal advocacy and our policymakers all the way across the globe. And in a separate analysis, there was a strong association between income and of the male sex workers and HIV prevalence, really looking at some of the economic disparities and this sex and survival continuum. Moving on to adolescents and young adults, we had a brilliant overview this morning in the plenary session, and let me just say that there were really 2 different stories that were going on. There was a review of adolescents in low and middle income countries in one presentation, and really began to look at things a little bit differently. Most of the cutoffs are less than 15 and 15 to 19 years old. This really looked at adolescents in that 10 to 19-year-old group. and really found that, as we would expect, that there's been sort of a reduction as we roll out antiretroviral therapy in new HIV infections by 37%. But unfortunately, the mortality has increased almost twofold, up 189%. There were marked differences with regard to these adolescents from 10 to 19 years old, with the women surviving more. And part of the explanation when disentangling this is that the young women were becoming infected at relatively young ages, and that the men were part of the natal cohort. The other thing that I think is emerging is the use of mobile technology for youth. We heard some information on this as well, and we saw some differences. It looks like I'm about to run out of time, and I've got way too many slides. Let me just sort of summarize a few things and move forward. There was a fair amount of prevention across a number of different groups, looking at the issues around serosorting and doing some modeling and whether that will increase the prevalence of syphilis, which was primarily associated among HIV-infected MSM in Europe, that's here in high-income countries. And with regard to mother-to-child transmission, option B plus had a couple of very interesting studies, and one of the findings is that the type of way that the model of delivery was very, very important, not only with regard to providing HIV antenatal testing, but also with regard to retention, with the best model being a referral from the antenatal clinic to antiretroviral therapy clinics for ongoing prevention. An interesting intervention looked at mother mentoring or task shifting in order to sort of improve our B plus model to what professors would prefer in their students as an A.
And Rick, I've got to stop you there. I'm sorry.
All right, I will just end by moving on and saying that I learned a lot from Lorinda Garcia, who really said that if we're going to really do anything for these this prevention agenda, we're going to have to really focus on the structures, and this is part of the formula. But last, we cannot do it unless there's the resources provided to carry on the successes that we've had so far. Thank you.
Thank you. Thank you, Rick, and thank you, everyone. I know you've had an incredible task of trying to reduce a lot into 15 minutes. We appreciate it. So next up is for Track D, we've got Vera Paiva. Vera is a full professor at the Social Psychology Department in the University of Sao Paulo, where she's coordinated the study nucleus of AIDS prevention, an interdisciplinary group since 1991. She has collaborated as a researcher and advisor with the local and the national AIDS programs, as well as various UN entities and other international foundations. Vera's research has been mainly on sexuality and health promotion interventions. Thank you.
Well, before I begin to report on Track D, I would like to thank the organizers and the wonderful assistant rapporteurs I have had the pleasure to work with this week. Here they are, here are my friends. Thank you all. In the course of this presentation, I want to focus on several things. For Track D, as for every other track, the conference began with everyone in a state of shock for the colleagues lost in the flight MH17. As emotional as this beginning was, it also emphasized the importance of politics and reminded us how much this epidemic has always been affected by political factors. The importance of politics was also clear in so many events leading up to this conference. For example, when WHO launched the consolidated guidance for HIV response among 5 key populations, men who have sex with men, prison inmates, and people who inject drugs, there was much of confusion, though, about the meaning in the media and even in the corridors of this conference. Sadly, some misunderstandings risked contributing to stigma and discrimination that have accompanied us since the very beginning of the epidemic. And the guidance emphasized the need to address critical enablers, including the decriminalization of these populations' practice and of the transmission of HIV. This highlights just how much, even in the era of major biomedical advance, no new development can be rolled out successfully without taking into account its social and political circumstances and consequences. This is why Track D and a focus on the social political factors is so essential in this conference. Over the 3 decades of this epidemic, I don't know what's going on here. Over the 3 decades of this epidemic, we have seen many shifts in terminology and conceptualization, from risk groups to vulnerable populations to now, it seems, to key populations. This recent change may in many ways be a regressive one because it masks the social nature of these groups. We must remember that the terms MSM, sex worker, and people who inject drugs, or adolescents, are themselves social products created by people like us and for specific reasons, political and social purposes. We should not ignore the mass of research findings presented in Track D sessions that consistently describe much diversity within each of these populations. The term key populations also fails to recognize intersectionality, namely the social inequalities, class poverty, race, ethnicity, and gender power that cut across all these key populations, rendering some of their members more systematically cut off, vulnerable, and at risk than others. Women everywhere, including transgender and indigenous women, about whom we learn a lot in this conference, do not enjoy equal rights. This leads to silence, violence, and vulnerability to HIV, in synergy with unwanted pregnancies, coerced abortions, and forced sterilizations that add to different dynamics of daily life. Time and again, panelists highlighted the need for adequate resourcing for collective organizations and participation. Community participation enhances understanding of the singular realities of daily life in which prevention and care are enacted. Life is complicated. Life is much more complex than even the most sophisticated clinical trials or the lengthiest program guidelines are able to capture. Put quite simply, there are many factors at play in influencing the way we are, how we think, and how we behave. Presentation after presentation at this conference highlighted how actions and programs need to be tailored locally, contextually, and historically. We need to better understand the specific and local epidemics in all countries. HIV responses must also take into account how people change throughout their lifespan and through different structures and cultural contexts. Participatory research, social research, has been crucial. It has helped us understand, for example, motivations to be either on PrEP, trust to the drug, access to care, reimbursement, or off PrEP, side effects, lack of need given condom use, post-trial access not assured. Social sciences reported as this conference also interrogates how new prevention technologies affect issues such as stigma, as in the Truvadas horse. Community participation can enhance understanding of the everyday context. As papers throughout the track stressed, it is often difficult to identify population needs when many sexual activities remain taboo, threatening, and poorly understood. At the same time, even after 25 years, sexual pleasure is largely been absent in prevention and care discourse, and sexual health remains separate from reproductive health, although pregnancies and HIV infection may occur in the same sexual encounter. And this is especially important from young people's perspective. The exploding epidemic among among young people was numerous presentations focused on what was consistently described as an exploding epidemic among young people. AIDS is the leading cause of death in adolescents in Africa, as well as the second cause of death globally for youth from 15 to 19 years old. HIV-related mortality is decreasing in all age groups, but increased among adolescents. Various sessions brought together young people and leaders from government and research and young people living with HIV who were quite vocal during Track D discussions, advocating for their proper and not token participations as part of the solution. At the same time, program implementers stressed that working in partnership with young people in the lead rather than speaking for young people was the way to go, and that combination prevention also works for young people when they are involved in its design and implementation. Sadly, the most often used option for confronting this crisis are plainly not up to the task because they focus too often on the perceived deficits of youth rather than on young people's creativity, resourcefulness, or resilience, and the importance of breaking down structural barriers that make it hard for young people to take meaningful action to protect themselves and others. We need better conceptualization of how these structural and programmatic barriers produce young people's greater vulnerability to HIV and AIDS. Again, not presuming a universal psychobiological profile and disregarding the enormous differences that gender, class, nation, sexual orientation, and the loss that informal education and health services can produce. Good intentions are not always matched with good programs. Throughout the track, there was clear evidence that all elements of HIV response are likely to be most useful, especially with most affected population, when they are tailored to the context, when they recognize people's autonomy, and when they ensure the engagement at all elements of the response. We cannot end AIDS through biomedical responses alone. We have the tools, but human rights and social protection are critical enablers of effective prevention and treatment. People need to benefit from new biomedical technologies, but voluntarily, consciously, and without any pressure. As in the case of harm reduction, opposition in the face of clear evidence usually comes from ideological positions, including the demonization of HIV and AIDS, the criminalization of key population, and stigma and discrimination in relations to substance use and addiction. The effects of criminalization throughout this conference, there was a clear evidence of the negative impact of criminalization in most affected populations. We saw in many sessions the epidemic of bad laws that criminalize populations and behaviors, and the lack of enforcement of protective laws. Bad laws perpetuate violence, hinder access to service, and violate human rights. They are key social and political barriers to a proper AIDS response in all continents. The legal situation in Nigeria, for example, is such that not only are men who have sex with men fearful of identifying themselves, but doctors, teachers, and other professionals cannot provide services to them to fear of prosecution. The adolescent epidemic crisis is exacerbated by laws that impede access to services, as the prohibition of provision of contraception to unmarried girls or adolescents' needs for parental consent to access HIV testing. By the age of 14, most countries consider young people old enough to stand trial for criminal offense, but many do not consider men old enough to make decisions about their sexual health or the health in general. This is absurd. There is moreover a lack of consistency across laws in many national settings about when young people can consent to sex, marry, or access sexual and reproductive services, which may all be disconnected from when young people actually start having sex. On the other hand, throughout this meeting, there was also clear evidence of the positive impact that well-designed structural approaches can have. Improving the broader legal and policy environment remains a major challenge for improving the HIV response globally. Different sessions throughout the conference exemplified action on social drivers to end AIDS and extreme poverty. This may be HIV-specific, like critical enablers of prevention and treatment, or HIV non-specific, like strategies for social and economic development, gender equity, and human rights protection. Investment in social protection in the form of cash transfers to girls or providing microfinance training and loan provision for drug users, while expensive, are cost-effective for countries as a whole. Participation, again, should be the cornerstone of this approach. Public and community engagement in science or research led by affected people has proved successful to ensuring greater access to healthcare and HIV treatment for most affected populations. But we are not doing enough of this. Although still underutilized, community-based empowerment is a promising approach to action with meta-analysis showing improvement in a range of HIV-related outcomes. It encourages social cohesion, collective participation, and access to services. Many presentations highlighted innovative community approaches to resist to stigma and discrimination, such as the use of social media, the internet, and mobile phones in outreach work with sex workers or with young girls and young gay men, as well as with indigenous people, youth more especially. These new media can combat hopelessness and isolation and also be powerful by reconnecting to stories of resistance and survival. In conclusion, and back to politics and the politics of evidence, I want to emphasize the fact that, as one Track D presentation put it, evidence doesn't speak for itself. It always has to be interpreted and translated into practice. We have the evidence, but this is not necessarily shaping policy change. This is particularly important as challenges are emerging on the horizon, including increasing treatment costs exacerbated by intellectual property and free trade agreements, alongside funding cuts at global and national levels, especially for middle-income countries. Perhaps the most troubling fact in this regard is that precisely the time when we have clear evidence of the effectiveness of a positive structural approach, we also see policies and programs that encourage us to return to an ineffective past. Nowhere is more evident than in almost obsessive search for a magic bullet for biomedical or technological solutions that might be successful independent of a structural change. What the research in Track D consistently highlights is the fact that even in the most sophisticated biomedical technological innovations take place in social, cultural, and economic, and especially political circumstances. Thank you.
Our next speaker is Bridget Hare. Bridget Hare is a lecturer in public health and medical ethics at the University of New South Wales, Australia, and vice president of the Australian Federation of AIDS Organizations. She has worked in HIV and sexual and reproductive health for 20 years as a journalist, editor, policy analyst, and advocate. Bridget acts as a consultant for the Australia-China Human Rights Technical Cooperation Program on sexual and reproductive health rights, and serves on the Data Safety Monitoring Board for the South African HIV Prevention Study, CAPRISA 008. She has a Master's of Bioethics and a doctorate on standards of care and HIV prevention research. Bridget.
Thank you very much, Owen. To begin with, I'd like to acknowledge the traditional owners of the land and to pay my respects to elders past and present. And I would also like to acknowledge the marvellous 4 women that I have worked with a great deal of enjoyment and awe. My team were Clara Henderson, Moronike Falayan, Jenny Butler and Deanna Kerrigan, and they have done the impossible day after day and night after night. So, Track E. Even seasoned veterans of international AIDS conferences ask, what does Track E actually mean? What does Track E do? Track E is about implementation research. It's about economics, systems and synergies with other health and development sectors. Now, this is a time of epidemic transformation, and implementation science is critical to finding the best way forward. We have effective treatment. We have an expanding repertoire of effective prevention interventions. some of which have been around for decades, like needle and syringe programs and condoms, and some, like ARV-based prevention, which are more recent innovations. We've got bold new plans and targets, but we still have people dying from HIV-related disease. Now, Track E has featured sessions on programmatic scale-up and sustainability, funding models, service integration, social protection responses, and the policy and legal barriers that create vulnerability to HIV in key populations, in a program and across diverse groups. So basically, the story of this conference is all about implementation. But the implementation of effective HIV programming faces challenges at the macro level. Structural problems of discrimination and stigma that make the development, the funding, and the implementation of evidence-based programs for people who inject drugs, for example, politically unacceptable in too many instances. And an epidemic of criminalising sexual practices and identities in the case of gay men and other men who have sex with men, transgendered people, and sex workers in many settings. Now, Vera has already talked to you briefly about the launch of the WHO Consolidated Guidelines. In this launch, it was explained the criteria for being defined as a key population for HIV, which include those who are experiencing high degrees of risk, vulnerability, and stigma, which in turn compromise access to services. So these include gay men and other men who have sex with men, people in prisons and other closed settings, people who inject drugs, sex workers, transgender people. It does not include specifically populations such as girls and young women who face increased risk and vulnerability, particularly in geographical settings like sub-Saharan Africa in this particular document. And Indigenous peoples were also absent. But after James Ward's persuasive plenary talk on Wednesday, I predict we might see the tide starting to change there and see Indigenous peoples recognised as a key population, and perhaps young key populations also specifically mentioned. Now, with respect to the WHO guidelines, the conference heard the rationale for the strong recommendation for making PrEP available to gay men and other men who have sex with men populations, due to the strength of the data from the randomised controlled trials, due to the observational follow-up, and to the research and acceptability. It's also important in this discourse to understand the recognition that the underfunding of harm reduction and sex worker services, which we'll discuss further, mean that PrEP must not be allowed to be a substitute for other effective prevention interventions like decriminalisation, like needle and syringe programs, and occupational health and safety standards for sex workers. The need to utilise a range of tools for key populations, social, legislative and biomedical, was emphasised, as was the need for the implementation of the WHO guidelines to include widespread negotiation and communication with healthcare workers. Now, further on the issue of PrEP, in a session on social challenges in ARV-based prevention, Professor Slim Abdul Karim advocated for real-world implementation of PrEP rather than ongoing demonstration sites. And this argument was based on three premises. Firstly, the PrEP works if you take it. Secondly, and most importantly, that it is a myth that PrEP implementation should wait until every person who requires treatment has it. Because, as Professor Karim pointed out, poor ARV access is not an issue necessarily about the cost of drugs, but it is a broader health systems issue. Thirdly, that implementation should be refined through implementation, not through data from artificial environments. So we should be looking at real programs, was the argument in that case. Now, much of Track E was focused on money. We heard that 50% of new infections in HIV occur in the key populations of gay men and other men who have sex with men, sex workers and people who use drugs. But nowhere near 50% of the funding is spent on these populations. For every $100 spent on HIV globally, only $1 is allocated to sex worker services. And the same applies to human rights-based work. It gets 1% of the funding, despite the widespread recognition that the people who cannot enjoy their human rights face increased vulnerability to HIV. My former colleague Susan McLean summed this up, saying that 1/10 of 1 year's drug enforcement spending would cover global HIV prevention for people who inject drugs for 4 years. So with overall global funding levels for HIV levelling off, there's increasing pressure to find more sustainable ways of resourcing an effective response. On Monday, in a session on trends in AIDS financing, there was recognition of the need for countries to increase their domestic investment rather than have a full reliance on donor funding, and to ensure that systems are in place to produce good quality, transparent data on which to base decisions about investment and resource allocation. In another session on finance, presenters from the mining industry shared details about the work in remote sites in Mozambique, in Papua New Guinea and in South Africa. In some of these settings, people have not seen a healthcare worker for 30 years, it was reported. These projects involve substantial investment from companies into health services for workers, which can reduce the burden of disease in the workplace, in the supply chain and in the customer base. This work, according to one of the presenters, is simply the right thing to do, and it makes economic sense. The focus on funding continued on Tuesday with sessions on public-private partnership, AIDS and the private sector in the Asia-Pacific region, and, as Vera has mentioned, a workshop on action on social drivers to end AIDS and extreme poverty. The broad lessons from these important sessions were the critical importance of recognising the social drivers of the epidemic and of marshalling resources and innovations at the domestic level and in the private sector, as well as through international donors, in order to achieve real impacts. With regard as to why business should invest in health, it was noted that productivity is the intersection of business and health needs. When health is compromised, so too is business. And on Wednesday, the conference heard of political bias regarding national and international funding, or lack thereof, on harm reduction. A concern was articulated that the Global Fund's new funding model may mean that people who use drugs in middle-income countries will be even less likely to access services than is currently the case. And currently less than 5% of domestic funding in priority countries is spent on harm reduction. National commitments to support harm reduction must be a priority, and arguments to shift the money from the criminal justice sector to the health sector really need to be explored. Funding was also a theme in a session organised by the International Treatment Preparedness Coalition. The need to focus on treatment targets for key populations was emphasised, as was the need to ensure funding support for community organisational activities which are required to address these barriers to access. So on the one hand, the epidemic is now more than ever in populations that are deeply affected by stigma, by discrimination, by problematic legal structures and by human rights violations. But on the other hand, there's both a tightening and a shift in funding resources. So our argument is not just about increasing funding. Sorry, I'll just go back there. But we now see a new focus on more efficient ways of structuring and delivering programs, more efficient allocation of resources, and funding to come from domestic resources. But funding can't come from domestic resources if the domestic environment is the one that is perpetuating stigma, discrimination, problematic legal structures. This is why we need both funding and access to comprehensive services, and in addition, we need to consider the needs of adolescents worldwide. Ultimately, implementation science is not just about developing logistical and technical efficiencies, but it's also about understanding and addressing the political and socio-structural challenges, including gender and social inequities that impede access to service and also impede the uptake of preventative behaviours. In turn, an implementation science agenda and program and policy funding must directly tackle these issues if we are to make breakthroughs that really are sustainable. On Tuesday, the Lancet theme issue, which has also been mentioned by Rick, on sex workers was launched. Most sex workers live and work under the threat of laws and policies that criminalise or discriminate. These structural factors continue to challenge the ability of sex workers to protect themselves from HIV and to live long and healthy lives. Importantly, sex workers themselves were authors on all of the papers. This series highlights the significant lack of funding globally for HIV programming for sex workers, and in particular the need for rights-based sex worker-led programs. As a global movement, we also need to talk very seriously about community engagement. Community engagement needs to be understood as not just being about talking to communities to get them to do things, to have their tests, to take their pills or to use their condoms. Community engagement has to be about empowerment. Empowerment of communities to organise themselves so they can communicate effectively and around the structural barriers that constrain their work, about the reality of their health needs and about where they perceive changes must happen. To achieve this, we need to fund transgender women, sex workers, gay men and other men who have sex with men in criminalised environments to do this critical work. And we've seen some instances of spectacular success in this conference, most memorably the Mentor Mothers program, where new mothers living with HIV work with newly diagnosed pregnant women who are facing the shock of an HIV diagnosis alongside a pregnancy. This program supports the implementation of Option B+. But as Delegate Dr. Susan Paxton asked, why are we not paying women professional rates to do this groundbreaking work? This conference has also had the pleasure and privilege of witnessing and experiencing the energy, the commitment, the passion and the strength of a new generation of community leaders, including Youth-Led, a community-led organisation of young key populations from across the Asia-Pacific region, which has become a powerhouse in the HIV response among young people. This has transformed the engagement of young key populations in the response. In addition, we've also heard some very important information about travel restrictions. Laws that restrict travel for people who are living with HIV constitute a significant incursion into the rights of people who are living with HIV, especially those who rely upon migrant labour for their incomes. Overall in Track E, recommendations for actions include a call for an end to the criminalisation of key populations, the inclusion of other often neglected groups such as Indigenous peoples, youth, particularly young women and girls, and further investigation and evaluation of integrating HIV services into accessible and sustainable health services where appropriate, within broader development and social protection initiatives. And continuing to build an implementation evidence base that focuses on collecting data on the effectiveness of interventions that address both the technical and socio-political challenges of operationalising advances in the field of real-world settings. We need to leverage the money and the innovations where it has most impact and where it fills the gap. Because 90-90-90 won't be achievable if the 10% that gets left out is the 10% who are key populations. As we have learned in many presentations over the course of this track, science alone cannot defeat HIV. Thank you.
Thank you, Bridget. Next, we'll have a readout on the Leadership and Accountability Program from Aditya Bandyopadhyay. Aditya is a lawyer, development consultant, and human rights activist based in New Delhi, India, and working across the Asia-Pacific region. Aditya has been an out activist for the rights of all sexualities since 1993, including playing a leading role in the movement for decriminalization of sodomy in India. He has also worked at the same time with the HIV/AIDS movement in South Asia for prevention interventions of male-to-male sexual transmission and for care, support, and treatment issues of PL/HIV, men who have sex with men. Aditya.
Hello, everybody. I want to begin by thanking my team, which consisted of Arthur Lim, Craig Bionic, Masood Bachus, and myself. I was leading the team. Other than me, every single one of them were young, energetic, dynamic, and almost made me feel like an old bag at the age of 42. I also want to acknowledge the fact that the Leadership and Accountability Program Committee of AIDS 2014 laid out for us a vision that helped us in our way. They laid milestones, they made our work much easier. The committee consisted of co-chairs Louis Binder of Canada, Anna-Marie Okafi of Australia, and Sunil Babu Pant of Nepal, and the other members were Mabel Bianco of Argentina, Bill Boatwell of Australia, Svitlana Moroz of Ukraine, and Sheila Tlau of the UNAIDS. The Committee on Leadership and Accountability let us know that this track is about inspired, committed, and accountable leadership, including those within and across governments and international institutions and policymakers, religious leaders and private sector, in the development field. The scientific community, healthcare providers, civil society, international and national organizations representing people who live with HIV and AIDS, and those working with them, grassroots organizations, donors, and the media. They told us that people living with HIV have to be kept front and center at all points while holding the leadership accountable for their actions. They encouraged us to recognize exemplary leadership when we witness it, and they emphasized the importance of partnerships amongst all sectors, which is one of the key roles that leaders can play. One of the first questions that we confronted was, is this a track or a cross-cutting theme? When we talk about leadership or accountability, can or should we merely have a set of sessions in a track in the conference and be done with it? Or should we seek out the elements of leadership that is present in every session, nearly every session that has been conducted here in the past 1 week, and take those nuggets home? Even as the answer is obvious, we realize that the logistics and rigors of a large conference like this one maybe makes it easier to focus on leadership and accountability issues if we put them in a track. But the attendant risk, as we understood it, is that we may lose out on capturing those nuggets of leadership being exhibited in almost every other session being held here in the past week, simply because we concentrated on the track. And therefore, we have this recommendation to make for future conferences. Please have a larger team of rapporteurs under this track so that it becomes possible to convert it into a truly cross-cutting theme. Enough manpower could possibly allow for sessions outside of the track to be covered for leadership issues. The sessions under this track can be broadly divided into the following 3 sets. The first were sessions that address structural barriers like bad laws, discrimination, violence, lack of support of key affected populations, social legal marginalization, lack of funding, scarcity of good data and research, political will, sometimes political ill will or lack of will, etc. The second set was sessions that addressed issues of development and change within the HIV universe, including those that looked at innovative approaches and projects that dealt with addressing some of the structural impediments and barriers. And the third set of sessions were sessions that developed capacity of the participants themselves, empowering them, skilling them up to take back effective, productive knowledge back from the conference, which can benefit their own communities back home. We realized that this conference is a space of concentrated expertise. People with expertise from all over the world were coming here. And this allowed the possibility of benefiting participants with knowledge and skills that these experts bring here, an area of accountability in itself, if we may say. The problem of resources and skill, the problems of resources and skills are present, yet leaders and stakeholders that we encountered across the conference over the last week made it very clear that they're willing to expose themselves to the scrutiny of their performance, thereby exhibiting an affinity for accountability. We found wide willingness by key stakeholders to develop leadership in such innovation and in technology that would ensure structural impediments are addressed to mitigate the adverse impact of HIV for key affected populations. This in spite of all the problems that we know we all encounter while we are trying to work with HIV. Before I go forward, I would like to address the issue of a perceived or real disconnect that we witnessed here, or we felt that is present here. And this is the disconnect between the worlds of the key affected population communities and the world of science. We observed that some of the best scientific brains here did not attend any of the community tracks or those that would have actually helped them in their work. Many of the community leaders here from key affected populations did not attend scientific tracks. Maybe they did not understand the language. A common language was missing somewhere. So we did like to raise a few questions for consideration for the collective leadership that is present here. Call it a challenge to the leadership if you want to. The questions are, how do we make community and science talk to each other? Can innovative leadership in each, that is community and science, reach out to the other? Who can facilitate a dialogue between community and science? And how do we ensure community and science each get out of their respective silos and complement each other? These are important questions that I think we need to ponder about. The next issue that I would like to address that we witnessed across many sessions that were part of the track as well as outside of the track was about social mobilization as an effective means of responding to the HIV crisis. Communities representing people living with HIV and other key populations were here in large numbers, and they put themselves through the litmus test of effectiveness of their leadership. We learned here that social action by communities in innovative ways across many parts of the world are addressing the challenges faced by communities. Community leaders in session after session let us know that social action is the best and most effective tool that can lead to effective prevention and quality of care. Unlike other epidemics that can respond exclusively to a medical response, HIV is as much a social problem as a medical one, and therefore needs a social action as much as medical action. HIV disproportionately affects those that are at the margins of society, targeted with stigma, discrimination, and abuse. Since there is no cure as yet, prevention is dependent on mobilizing these very communities in an environment that allows them to feel safe and to seek tools of safety and information. Those that have already been infected face a double stigma, one of being from a marginalized population and the other of being HIV positive. Again, their care, support, and treatment can be best addressed if they themselves are kept front and center of their own issues and their rights are secured in an environment that allows for non-discriminatory and non-judgmental service provision. Social mobilization, again, is the key. The question that we can assist in this social mobilization of empowerment, decrease in stigma, elimination of discrimination, etc., leads us to believe that effective leadership can actually play a very important role in dealing with what is a universal crisis. Even as we have said before, silos need to be broken. So here is a set of questions again that we pose to all leaders, be they political, scientific, academic, researchers, or social leaders, or they belong to communities. We urge you to ask yourself every step of the way, while you work for mitigating the impact of HIV, what are the problems in social mobilizations of those in the margins and of those that are infected? What role can you as a stakeholder play in alleviating the situation? How can you ensure that the skills of key stakeholders from legal, medical, journalistic, and caregiver fraternities are developed to provide accountable and responsive services? And how can you create synergies between the stakeholders and the recipients of care and services so that we have a unified voice against the pandemic and ultimately we realize the fact that no one is actually left behind? I would like to speak also a little bit about the leadership represented here by the pharmaceutical industry. Over the duration of the conference, we experienced the tension that pharma and industry often have with key affected populations. However, we note with hope that leaders from both ends of the spectrum are making an effort to understand and appreciate the constraints under which each operate. While community leaders acknowledge that pharma and industry are essentially profit-driven, they also realize and appreciate that it is profits that drive research and scientific development, which ultimately benefits the community. On the other hand, leadership of the pharma and industry also exhibited the willingness to listen to communities and their needs. We were given enough information here to believe that pharma and industry are aware of the community's needs and constraints, and they are willing to be more open in the future. Constraints of adequate funds that communities face is something that the pharma industry seems to be aware of. We feel that leadership of the pharma industry is willing to maintain that fine balance which ensures profits remain within equitable parameters and do not cross that line which makes it usurious. I would like to address the question of leadership responses to barriers. There are social barriers, and that just reminds me that I forgot to change the slides. I'm sorry. Happens. I would like to address the question of, is that the one?
We're still with you, don't worry.
Yeah, I'll get there. Okay, so we come to the question of barriers. What are the socio-legal, socio-political, socio-cultural, socio-economic barriers that are faced by those that are either the most impacted by the HIV pandemic or have been infected by HIV? The sessions were bracketed and highlighted by the voices of communities that have to face the adverse brunt of the above barriers. We heard from them stories of their life situations, what they were doing in their own capacities, how they were nurturing leadership with innovation, often showing exemplary courage and dedication to mitigate the adverse impacts of these barriers. Once the communities identifies these barriers, the problem becomes finding ways and means of overcoming them in a manner that reduces, if not eliminates, conflict and strife, and augments a human rights affirming environment that allows for the protection and promotion of the best interest of those most at the margin, most at risk, those most adversely affected by HIV. The social legal barriers comprise of bad laws that often criminalize, discriminate, does not allow access, or simply ignore those that need to be served with the greatest amount of legal protection. Bad laws also foster a social environment of impunity against the marginalized and most at risk. It is leadership of judges, of lawyers, of political personalities that need to be fostered and nurtured to address these impediments. Sessions dealt with these issues in some details. Religion is the next issue on social barriers that we saw being raised in many sessions. Religion is a mixed blessing, where on the one hand it can provide moral, spiritual and emotional support, not to speak of the actual care that many religious institutions undertake in an act of selfless charity and service. On the other hand, it also fosters a judgmental environment that promotes and proliferates stigma, discrimination and sometimes even violence. We heard how the religious groups in Uganda and Nigeria fanned homophobia that allowed for extremely backward and human rights demeaning laws to be passed in these countries against homosexuality. This has been a setback to the HIV/AIDS effort in this country. We heard how sex workers in many places could not seek even basic human rights protections because of the anti-sex attitude nurtured by dominant religion. Even as a high-level delegation from Bangladesh was here, Bangladeshi sex workers were being evicted with violence in Dhaka. We also heard how these bad laws then lead to a situation where prevention, care, support and treatment of those most at risk become an impossibility. There is a clear and immediate need for interfaith dialogue and a dialogue between religious leaders and leaders of science and leaders of community to mitigate any adverse impact that this situation does perpetrate. On gender issues, we heard the voices of the transgender community and of marginalized women, young women. We saw how dominant masculinities create barriers that lead to violence and abuse, how laws are gendered and leads to similar abuse. All of these impede protective policies from being effectively implemented even where they exist. In many places, they do not exist.
Titi, I'm sorry, that's time. So if you want to wrap up, thanks.
Okay. So we heard about all of these social barriers, etc. We also heard from the political leadership that was present here. One of my friends actually summed up the question of political leadership very neatly when she said, I find a lot of political leadership here without accountability, and I also find a lot of community people here being held accountable without a lot of leadership.
Thank you, Aditya. Thank you.
With that, I would end my session. Thanks.
Thank you. I'd like to welcome up Len Tooley. Len hails from Turtle Island, which is an Aboriginal name for the territory also known as North America. Len currently works in Toronto as an HIV tester and sexual health counselor, providing low-barrier services to gay men in bathhouses. He also works with CATIE, Canada's National Organization for Information on HIV and Hepatitis C, where he coordinates projects that help inform gay men about new options for HIV prevention and treatment, work that is closely tied to his personal relationship to HIV and decision to fight to be prescribed pre-exposure prophylaxis, despite the fact that Truvada is not approved for this use in Canada. Len.
Thank you. Just out of curiosity, how much time do we have left for this session?
You'll see it right next to you right there.
No, I mean like overall. Because I think there's two more people behind me, and I know that we're
good on time. You've got there.
All right, okay. Just wanted to make sure. Hello, everyone. Really happy and excited to be here and to be sort of speaking to and about the community aspect of the conference. I want to also begin by acknowledging the Kulin Nation, the traditional custodians of this land, and their past, present, and future elders, and recognize that I am really honored to be a visitor here. It's been an incredible opportunity, and it's my first time in Australia, and it's a pretty great country. Before I start, I wanted to introduce you all to the team. I'm not sure if I can't really see them. They told me that they were going to be sitting with each other. There's some hands up there. There's a couple shout outs. Catherine Shepherd, Che Gossett, Dean Camilleri, myself, Paul Simugoma, Smarajit Jana, Simon Powell, and Tony Judson all worked really hard over the conference to hear the voices of the community and to listen to sessions to try to tease out what was relevant to community. It's really tough to go to so many sessions and hear so many voices and then have only 15 minutes to reflect a lot of what was said, but we'll try our best. And to those people who did share their voices with us, we just wanted to say thank you, and that we will take them with us even if we don't get to speak about them in this presentation today. So, community is a really broad question, and if there was a little tab in the book that said, oh, here's where you can go to get community, it would have made our jobs a lot easier. Unfortunately, that wasn't the case, and that's probably a good thing in the end. But we started out really thinking about sort of exploring what community was. And also acknowledging that there is probably no one community, that there are many communities. But it was really interesting to see this focus on key populations as a new term that was really being hailed as an important term, and to see a lot of people think that was really important for them to be acknowledged as. So there was a really sort of interesting discussion, I think, about sort of tearing apart or taking down these categories and wondering who gets to sort of call themselves a key population and who are they speaking to when they do try to speak as a key population. The value of being a key population is that you're not one of the previous sort of terms, like you're not necessarily just inherently vulnerable or at risk, which are terms that can be really disempowering and don't acknowledge the fact that people are really actually doing a lot to manage some difficult situations, and they're thriving in their lives in many ways as well. To sort of reflect that a little bit, on Monday, one of the first sessions I went to was titled "A Community Dialogue on Key Populations: Who's in, who's out, and why," and it really couldn't have been a better way to start the week. There was quite a bit of discussion about what key populations were and why we use the term at all. And I couldn't help but quote Doris Peltier, who's an Aboriginal woman and a leadership coordinator for the Canadian Aboriginal AIDS Network. When she spoke about how in her Aboriginal community, the key populations that are sort of officially identified are women, youth, and MSM. But that really left out a number of other people who are also really affected by HIV, such as trans people, prisoners. And so she questioned the value of the word being a key population, and noted that there weren't many dollars attached to it, and noted that when talking about key populations, that she wanted to acknowledge that as a woman living with HIV, that she had a voice, but not all of her sisters did. And I think that one of the things that we have to really consider when we think about who are key populations is that when we try to define and distinguish groups like that, then there's always going to be people that are going to be left behind in some way. So over the week, I've really come to reflect on how each of us is really a unique intersection of a lot of different communities. We take part in different communities, and they're sort of all come together to create our overall being. So like threads woven together to create a fabric, each of us is enmeshed within a network of interwoven and overlapping communities. Sometimes they're really tightly interlaced, and other times they're threadbare and frayed. Each of us has our own unique pattern and our own unique experience in relation to the mixture of communities that we move in and out. But locating a person's experience in relation to only one of the communities that they belong to can sort of distort our understanding of how community works in concert with the other fibers of the other aspects of our personality. So a neat analogy that came to mind was, like when you have a little bit of one of those like loose threads on your elastic and you pull it out and it sort of distorts the overall fabric. Thinking about key populations and defining people based on one aspect of their identity, it sort of does a similar thing. You're pulling out one thread of their story, and it doesn't necessarily give you the entire picture of their whole experience and how they might be key populations in many different ways. So naming, identifying, and addressing key populations, just as one might want to pull a single thread from a woven fabric, is really challenging. In naming and identifying with any one key population, do we risk pulling the rest of the fabric apart? And how much can we say about a rich tapestry when we're only looking at its threads? How can we tell how it comes together? So this is a question that sort of we explored and thought about. So I have 8 minutes, right? Yep. It's sort of hard to see here. So to go back a little bit to the Community Programming Committee, which selected us as rapporteurs and brought us here. I've listed some of the goals that the Community Program Committee had as they really carefully considered how to reflect and integrate community as a concept into the proceedings of the conference. So some of their goals were to really ensure the greater involvement and meaningful engagement of people living with HIV. They wanted to see that when people speak words and make commitments, those words actually result in actions and result in certain kinds of change. They wanted to celebrate the successes of all the communities that have actually done an incredible amount of work and succeeded on their own to address HIV in very different ways. They wanted to acknowledge and prioritize key populations, and like everyone has been saying, leave nobody behind. In terms of our approach that we took as a team, our mandate was to capture as best as possible the voice of the community at the conference. So if you are a scientist or a policymaker or a clinician or a funder, this presentation is basically for you. We acknowledge as community members in different ways that it's hard to attend all the different kinds of sessions at an entire conference. And we all have our own sort of like actual interests and needs and professional demands that we need to meet. So this presentation is a little bit of the Rapporteur's team attempt to bring those community voices that you might not have heard back to you a little bit. But before I really get into it, I want to try a little bit of an experiment out. If you might not have noticed, but in the previous slides, there's a web address down on the bottom of the slide. And it's for a website called Today's Meet. Now, I don't see people taking out their phones, but I would like to. So anyone who doesn't have their phone out or their computer, this is actually a really great opportunity for you to do it. It's an excuse. You can check your emails if you want. What this tool does, it's very, very simple. You type in your name. So you go to the website, you type in your name, and then you can make comments and have a sort of a backline chat. So as this conversation goes on, we really wanted to emphasize that we can never capture communities like one community's voices, and that actually everyone here is part of a community in some way, and we can all speak, we can all be rapporteurs. So I'd like to see you, if possible, reflect and make comments on the rest of this presentation. That's a little screenshot of what it looks like. So it's quite simple. You just type in your name, whichever name you want, and click join, and then you can see what other people have said and their comments and thoughts. So preparing for this presentation, I read somewhere that this is the 20th International AIDS Conference, and it's basically been 30 years since the very first International AIDS Conference. So they haven't always been every 2 years. And before I came to Australia, I was forwarded the Community Rapporteur Summary from 10 years ago, which is 5 conferences ago, to see what the conversation was at in terms of a community perspective. A member of ACT UP, which is an activist organization in New York, he had written sort of a speech about it. And these are some of the themes, some of the main challenges he brought out in his speech. I thought the first one was really interesting because it didn't seem to be that different from, in a sense, what we're talking about a lot throughout this entire conference, which is really, can we talk about access just with respect to ARVs? At the time, abstinence, be faithful, and use condoms was still a pretty popular mantra, and there was concern then that people were really only focusing on abstinence and be faithful, and often were forgetting to even mention or talk about condoms in any way. So there was a need to remember that condoms were a really central tool. Women seem to have been perceived at the time as a homogenous group. So in 2004, it was acknowledged that they didn't hear the voices of women drug users or women prisoners, lesbians, trafficked women, the girl child. So this sort of reflects the idea of these intersecting and woven identities, right? And I think today we still see that when we don't necessarily explore the complexity of what a transgender identity might be. There are many, many gender identities. And so there's a lot of opportunity for us to grow and explore and really become more nuanced about our understanding about how people work. They also asked, how do we hold our leaders accountable and stop accepting promises that don't get kept, which can result in people dying because they don't have access to services or treatment. And lastly, they argued that we have to put sex back into the epidemic. It wasn't sexy enough. So an interesting sort of revision, or to look back 10 years ago, what I sort of thought when I read through these is that while some things, the more things change, the more things stay the same. We see some similar patterns, but in sort of different ways. So in 2004, the community asked if we can reduce questions of access solely to questions of access to ARVs. And it's sort of ironic or interesting because just this year, as everyone probably knows, the UNAIDS Executive Director, Michael Sidibe, set this new ambitious 90-90-90 target. So I thought I would talk a little bit about that. The idea is to get 90 people of HIV diagnosed, 90% of people on treatment, and 90% of people, I think that the term is to an undetectable viral load. And it really just, so the numbers sort of build on, right? So 73% of people living with HIV who have fully suppressed viral load by 2020, where right now, 37% of people living with HIV are considered to be receiving treatment. And that coverage varies widely between countries. So the interesting reflection was that 10 years ago, the 3x5 promise was the big deal. What a lot of was pointed out by presenters, by community members, was the huge disjunction between global policies and local realities. So what we've seen is that despite using numbers like a certain percentage of people are on treatment, that being on treatment is not necessarily it doesn't necessarily mean that it's a stable treatment. So many countries in the Asia Pacific region are using stavudine, which is a horrific drug that has horrible side effects. In many places in West Africa, people have very little or no access to second or third line treatments. So one of the questions that comes up a lot is when we set these targets of 90-90-90, who becomes the 10, 10, and 10? I'm just going to quickly go by because my time is pretty much up. That went way faster than I thought it was going to be.
Yeah, sorry, your time's up if you want to summarize.
Okay, yes. So basically, I have a question for everyone, which is if you had a message as a community member, as representing your community, that you wanted to make to policymakers, to funders, to researchers, And to service providers, what do you think you need? Community members basically say that we need ownership of our services. We need full decriminalization of our identities, which means, for instance, with sex workers, decriminalizing the whole range of sex work, not just people who perform sex work, but also the places where they perform sex work, and the clients who buy sex.
Thanks, Len.
Thank you.
Yeah.
Okay, thanks very much.
We all underestimate how stressful it is being at that podium. There is a lot that's right in front of you, so thanks everyone. Next up, we've got Dr. Clive Aspin. Clive is Maori, an Indigenous person from New Zealand who lives in Sydney, Australia. He has been engaged in the struggle to overcome HIV for more than 30 years. As a community prevention worker, the chair and board member of a number of HIV-related governing bodies in New Zealand. As a government policy analyst and as a social researcher in HIV and Indigenous health, he has collaborated with Indigenous researchers in Australia, New Zealand, and Canada. Clive.
Tēnā koutou katoa, ko tēnei te mihi atu ki a koutou. Ko haere mai nei ki tēnei hui I tēnei rā, nō reira tēnā koutou, tēnā rā tātou katoa. That was my way of greeting you in an official language of New Zealand, of which there are 3. It also happens to be the Indigenous language of New Zealand. On Monday, delegates were warmly welcomed to country by Auntie Caroline Briggs and Auntie Di Gray, who invited us to enjoy this beautiful country, but also they urged us to respect the ways of the traditional owners. I'm here to report that the thousands of people who came from the 4 corners of the globe respected the wishes of these esteemed elders by celebrating the diversity of cultures from which we have all come. So I'd like to begin by thanking the Wiradjuri and Boonwurrung people of the Kulin Nation for allowing us to meet on their land. We were also welcomed by the chairs of the organising committee, Marama Pala and Mohammed Barry, who welcomed us in their traditional ways and enthusiastically called on delegates to embrace the conference theme of stepping up the pace. The importance of the Global Village as the hub of the AIDS conference was further emphasised by leaders and dignitaries who joined in the opening of the Global Village. Their presence helped to remind us that the Global Village really is the heart and the nerve centre of the AIDS conference. The celebration of diversity that was on display throughout the last 5 days has borne witness to the fact that the Global Village is also the place where serious issues that impact on all of us are discussed, debated and celebrated. The dominant theme that emerged for our team, myself, Christian Hui from Canada, Apihaka Mac from New Zealand, and Nick Holas from Australia, was the need to bolster efforts to preserve and enshrine the human and sexual rights of all peoples and communities affected by HIV. This was on display throughout the conference, but especially in the Human Rights Zone, where community groups gathered to discuss how human rights impacted on their lives. We lost count of the number of times we heard people talking about the impact of stigma and discrimination, exacerbated by the abuse of human rights on their lives. Indigenous peoples and cultures figured prominently in the Global Village. After 30 years of HIV and 20 international conferences, Indigenous peoples are laying claim to their rightful place at the table in addressing the impact of HIV on Indigenous communities around the world. With significant HIV disparities in many countries, and especially in Canada, the Global Village provided clear evidence that Indigenous people with HIV are at the forefront of the fight to protect our human rights and to prevent HIV transmission within Indigenous communities. Indigenous peoples in the Global Village on numerous occasions also called on the International AIDS Society and other international organisations to recognise Indigenous peoples as a key population group affected by HIV, alongside other key affected groups such as people living with HIV who continue to face stigma and discrimination after more than 30 years of HIV. We heard from Lorinda Garcia, an HIV-positive leader who told us that the levels of stigma and discrimination experienced by people living with AIDS, with HIV, have increased in the last 2 years since the Washington conference, and this was reinforced here throughout the global village. And it was further reinforced by Bill Clinton, I understand, when he spoke in this auditorium the other day. Sex workers too described ongoing discrimination, and like other affected groups, they called on countries to recognize sex work as real work and to decriminalize sex work so that sex workers might enjoy the same protection and rights as everybody else. I attended a dynamic workshop in which sex workers from the Kandu Bar in Chiang Mai in Thailand described how they had taken control of their own working conditions and how they provided innovative training in safe sex practices for both workers and clients. We were reminded of the absolute importance of ensuring that sex workers are present at discussions and development of policy that impacts on the health and well-being of sex workers and the conditions in which they work. In the many years that I have been coming to these conferences, this is the first time that I have seen such a strong and vibrant presence of trans people. When it comes to stigma and discrimination, trans people, as well as women and men who have sex with men living with HIV, these people continue to experience stigma and discrimination to a far greater extent than anybody else. Among the human rights abuses we heard from the global village, we were reminded that these are often, sorry, I'm jumping ahead, that these, sorry, we were reminded they are often rejected by their families, they are denied access to antiretroviral treatments, they are refused surgery, they are subject to violence by authorities, and trafficking laws are used to restrict their travel. Abuses such as these can only be eliminated through the repeal of bad laws and the implementation of good laws. Initiatives need to be supported and encouraged by the United Nations, as we were told in one of the Meet the United Nations Leaders sessions. And we need to recognise the particular challenges faced by gender diverse communities, women who do sex work, women who use drugs, women as mothers, and women as caregivers. Initiatives to promote the health and well-being of men in Arabic countries were highlighted in the global village. We heard about the launch of an exciting new initiative called M Coalition that brings together networks across the Middle East and North Africa to fight discrimination and promote increased awareness of the needs of men who have sex with men in that region, a timely intervention to confront increasing rates of HIV among Arabic men who have sex with men.
Clive, you're at time if you want to summarize.
The main stage of the global village hosted diverse and vibrant expressions of culture. From our neighbours to the north, Papua New Guinea, with whom we heard about the particular challenges faced by people living with HIV, 85% who live in remote locations have poor access or no access to resources and treatments. To our neighbours to the southwest, New Zealand, where I come from, and where we saw the vibrancy and beauty of young people promoting their culture through fashion and design. On numerous occasions, we were reminded of the importance of working together in partnership with one another. The Indigenous Peoples Networking Zone was honoured to host the president of the IAS, Professor Bare Sinusi, who thanked and congratulated people on their achievements to date and reminded us all that we must keep on fighting, a message that applies to all people affected by HIV.
Thanks.
Finally, we need to remember that there are many people who have been living with HIV for many years, and we need to celebrate the wealth of knowledge and experience that they bring to the struggle against HIV. There are many reminders throughout the global village of the contributions that people have made living with HIV since the earliest days of the epidemic. We need to learn from their experience and celebrate their contributions. As we prepare for the next global village in Durban in 2006, let's not forget the sentiments of the elders who welcomed us to country on Monday, who called on us to acknowledge and celebrate our diversity and learn from one another as we work together to overcome this epidemic. Until we meet in Durban go well, let's hope that we'll be able to have action that will lead to a reduction in the stigma and discrimination faced by people and communities affected by HIV. Thank you.
Clive was a real sport there. The timer stopped and stopped working a while ago, so go you for improving. Thank you. So Sally is up next, and Sally, I'm sorry that you're only going to get 5 minutes here, but Sally Beadle is a research fellow and project manager at the Youth Research Centre, University of Melbourne. In 2011, she served as an Australian Youth Ambassador for Development in Thailand, where she worked closely with Youth Lead, Asia Pacific's interagency task team for young key populations, and I don't want to eat any more of your time. So.
Good afternoon, everyone, and a special welcome to all the young people and Youth Force participants we have here today. It is my pleasure to report on the strong and vibrant youth program that has made a significant contribution to AIDS 2014. I would like to say a special thank you to my fellow youth rapporteurs who worked tirelessly and enthusiastically throughout the week. This conference calls for more strategic investments in adolescents and young people. Globally, adolescents are the only age group in which HIV-related deaths are increasing. They are more likely to die from AIDS than any other group. AIDS 2014 has highlighted that adolescents and youth have not received sufficient attention in programming, policy or research efforts. Without significant attention and investment in this area, we will not be on track to achieve an AIDS-free generation. Despite this, the conference has shown that many adolescents and young people themselves are stepping up as leaders. They are making positive changes in their communities, and they are calling for more meaningful involvement of their diverse communities in the overall response. They are producing evidence about what is possible when this happens. Last week, 100 passionate young leaders from 56 countries engaged in the Youth Pre-Conference, a joint initiative of the Melbourne Youth Force and young people work together to put the health and wellbeing and human rights at the heart of the post-2015 agenda. The pre-conference showed that young people have the courage and capacity to speak out on issues that need addressing. They are not just the emerging leaders of tomorrow, they are leaders and advocates in their communities now. This global team of young leaders developed a youth action plan presented to the UNAIDS Executive Director on Tuesday. The action plan has 4 themes: treat, educate, reform and love. And with permission, I will use these themes to structure the rest of my presentation. Treat. We have seen that as treatment becomes more readily available, more children are surviving into adolescence. Several sessions highlighted the importance of facilitating a smooth transition for these children from paediatric into adult care. Many adolescents struggle as they move from familiar, child-centred environments into adult clinics. This contributes to poor adherence amongst young people. Young people at this conference are calling for youth-specific and youth-friendly treatment services. They want health workers who communicate with them rather than tell them what to do. At the same time, health workers want tools and training to help them work appropriately and effectively with this group. The Bailey Uganda Clinical Centre of Excellence was highlighted across several sessions as a positive example. It provides a peer education program to young people living with HIV, in which they can open up, encourage and support one another to live positively and adhere to their medication. Educate. We can't treat our way out of the epidemic, and education is an important aspect of preventing new infections. Ignorance and denial are health issues. Young people are pointing to the continued silence around sexuality and the denial that many young people are sexually active. But young people do have sex. While some may wait until they are married, many do not. Some have sex with the same sex, some with the opposite sex, and some with both. Young people want information about sex and sexuality. In the opening ceremony, Ayu Oktaryani, an inspiring young leader from Indonesia, said that many young people like herself are vulnerable because they are neither given the information they need nor the means to protect themselves. Young people from key populations have called for sex education that thinks outside the box, goes beyond heteronormative assumptions, and recognises and celebrates multiple sexualities and gender identity. There has been a strong voice of Indigenous young people at AIDS 2014. This week, we saw the launch of Anthem, the Aboriginal nation's Torres Strait Islander HIV youth mob. They join a global Indigenous youth and HIV movement seeking recognition of their unique needs, including culturally appropriate education. Reform. There is an urgent need for legal reform. In many countries, laws and policies restrict young people's access to HIV and other SRH services, including harm reduction. The age of consent to services has been a key focus of discussion. Requirement for parental consent for testing was raised by many as a deterrent for young people who cannot or do not want to discuss drug use or sexual behaviour with their parents or guardians. Findings from a recent online survey launched by the Pact, a collaboration between 25 youth-led and youth-serving organisations, was shared, calling for parental consent to be a choice, not a requirement. Strong arguments were made that laws and policy should recognise the evolving capacity of young people to make decisions regarding their own health. Age restrictions to parental consent and parental consent requirements to harm reduction services, along with abusive law enforcement practices to young people who inject drugs, were emphasised in many sessions as increasing risk. Youth Rise has stressed the need to remove barriers to harm reduction for young people under 18. Harm Reduction International and partners introduced Step by Step, a tool to help harm reduction service providers deal with the practical, legal and ethical issues of working with young people who inject drugs.
Thanks, Sally. We've got 1 minute left.
Okay. Let me just highlight that to assist with these actions, WHO and partners have released a draft technical guidance briefs for young people from key populations, which are very warmly welcomed and have been based on widespread international consultation. Young people are also included in the WHO Consolidated Guidelines on HIV prevention, diagnosis, treatment and care for key populations launched this week. And last but not least, young people are calling for love. They are calling for acceptance and respect from their communities, their peers, their teachers, their health workers and their governments. They see that stigma and discrimination fuels this epidemic. They see that respect for difference and diversity is at the heart of change. Throughout the youth program, they have stepped up to show what this love looks like in action. They have shown us that they are working hard, but they are ready to be more meaningfully involved in the design, implementation and evaluation of policies and programs that target them. They are the experts on their communities and they have the passion, determination and courage that is needed to play a critical role in moving us towards an AIDS-free generation. Thank you.